Hi everyone, thanks for joining. We are just going to give it another minute just to allow people to log in, and then we'll get started, okay? In response to your question, Kia, sorry, I hope I've pronounced that right. Yes, I think we will be sharing the content. We're just working on how best to share it. I think we're working on a website at the moment, but we will keep you posted. Okay, it's 2 minutes past. I'm sure people can just join in. We've just got a packed session, so I think it's good if we just get started as soon as possible. So, welcome back to the PSA series from MedTech. This is session 2, and the focus could be more on the prescribing, and there's also some leftover bits from the calculation skills. So, we've got your two lovely tutors today, Julie and Tess, and they'll just go into a bit more about what they're going to cover today. So, I'll let you guys take it away.
Hi everyone, welcome back. So for those of you, like Vicky said, we'll spend this session going through prescribing and calculation. In the first half of the series, we'll run through some tips and advice about each section of the PSA in particular, and then we have about 10 example questions, and we'll run through all of the answers for those as well at the end. And as always, if you have any questions, put them on the chat, which you can access on the right-hand side of your screen, I think, and we'll do our best to answer them as we go along. So if you could switch to the next slide, please, Vicky. So just a little bit about who we are, first of all. So METIC is a teaching organisation run by F1s. We're supported by Health Education England. What we do is provide free, accessible teaching resources to medical students. This is one of our series that we do. So we'll be doing a PSA series session every Thursday for the next 3 weeks, and you can keep up with that on our social media. And then we also do Thursday 15 series, which is our finals teaching, which will also be every Thursday, and it will start at around springtime, and that will be for revision for your finals. So that's us, and then we'll run through just really quickly the exam format as well. So as you probably already know, you have 120 minutes to complete the PSA. The PSA is made up of 8 sections. We'll be covering section 1 predominantly, and a little bit of section 5 with some calculation skills. It's a mainly time-pressured exam using the BNF or Medicines Complete, whatever you choose. And section 1, which is the prescribing, is probably the most time-intensive session. Not time intensive, it will take you probably the most time, and should take you the most time, because it has the most marks out of the whole exam. I think it has about 40% of the marks of the entire exam are in section 1. So we'll go through that in more detail as well. And then this is our suggested timing breakdown for the exam. So per section, as you can see, prescribing has the most marks per question, and so we've allocated that the most time. And then we've just given a rough suggestion of minutes per question. It would be a good idea to practice with these timings when you're doing your mock papers, and get a feel of how quickly you can look through the BNF and answer all of the questions in time. We'll be practicing some of the timings later with the prescribing questions as well. And then moving on to prescribing. So this is just a bit of a repeat from our last session, but this is more for those of you that just need some reminding. So the prescribing section is made up of 8 questions. It will include a brief vignette of the patient, their symptoms or their condition that they're diagnosed with, any examination findings, any investigations and or past medical history. And then the question will ask you to prescribe the most appropriate drug for that patient's symptoms or that condition that they have. Each question is 10 marks, and half of that marks will be for the correct drug, and the other half will be for how you prescribe it, basically. So that will be the correct dose, route, or frequency. The questions are likely to include an acute scenario, so that might be like an MI or a stroke, some chronic disease, and will include at least 2 fluid prescription questions, which we will run through in more detail. The most important section of the BNF for this section is the treatment summaries, and some of the high yield topics that we think would be good to go through before your exam are insulin, opiates, antibiotics, fluids, anticoagulation. And I think our questions probably include a little element of all of those today. So this is just a screenshot of the PSA mock question that is just available for free on the website. So this is just what it will look like for those of you that maybe haven't had a chance to have a look at the PSA format. The question will ask you to give you the name of the medication, the dose, the route, and the frequency. So I think from what I remember, it won't be free text. So as soon as you start typing in the medicine box, it will come up with a suggestion of things that you can click. So there isn't really a chance of prescribing things with an incorrect spelling mistake. And your prescriber signature and your date will already be input for you. So you don't have to worry about that during the exam. And just some other kind of quick little tips for the prescribing section. I personally chose to double check everything with the BNF, even if I thought I knew it. This was just because the prescribing section is so valuable for marks. I just didn't want to lose anything. And I think it would be a good idea, if you have some time, either during that section or some time at the end, just to double check things. And to check the individual drug doses for each indication. So one drug can have multiple indications and therefore can have multiple doses. So just make sure that you don't just write down the first dose that you see on a drug page. Actually check it with the indication and if it's correct. And also, if they give you a big old vignette of the patient in that question, just double check any cautions or contraindications for the drug that you're prescribing with the information that you're given. It might be that they're just giving you that information to kind of put you off, but sometimes it might actually just be quite useful and relevant to what you're prescribing. And also I've put Control F in a love heart at the top because it will be absolutely your best friend. Remember to Control F everything. It will take you straight to the most relevant section of the BNF. And then this is the same slide as from last time. So this is just some high yield treatment summaries that I would recommend getting familiar with, just to know what information is there and what information isn't there and what you might need to revise and memorize. The BNF definitely has a lot more information than you think. And probably if you had unlimited time, you could probably answer the majority of the whole PSA exam with just the BNF. So everything should be there for you if you can't remember it. And then if we just quickly go to calculation skills. So this is section 5 of your exam. It includes 8 questions, which are about 2 marks each. Most questions will be 2 to 3 steps, but definitely prepare for 3 steps. So that will be a question that involves you maybe doing 3 small calculations to get to the final answer. I think more increasingly the questions are becoming a little bit more likely to be 3 steps. So definitely prepare for that. They're fairly easy marks to score, and you do get an on-screen calculator, but that can be a bit clunky and a bit time-consuming to use. So I'd definitely suggest bringing your own calculator, but this has to be a basic one, not a scientific one, or anything that can store information. So before your PSA, just make sure you've got a physical basic calculator that you can use and bring it with you. And bringing a pen or pencil with you so that you can write down your calculations on a piece of paper. This is just so that you can write down everything step by step, and just when you're double checking your answers at the end, it will be really useful for you to be able to see your own thinking and see maybe if you've gone somewhere, if you've done something wrong, like put a decimal point somewhere where you shouldn't have. So those are my little tips for calculation skills. And then so this is something that someone told me with my calculation skills, and that was to do a logic check. So when you get an answer, just think to yourself, does that actually logically make sense? Does it sound logical to prescribe 101 tablets for a patient, for example? So just doing a quick logic check when you get your answer. It's a good idea. And if you get an answer with a decimal point, it doesn't necessarily mean that you've done it wrong. You might need to round the answer if you get a decimal point and the question is asking about a number of packs, for example. But you may not need to do that if it's for an infusion or an injection. So just make sure, just double read the question, just check if it asks you to round or not, or if it's appropriate. And the other thing, oh, sorry, Vicky, if you just go back a little bit. The other thing is to just get familiar with converting between different units. So I've put a little bit on the right-hand side about going between milli, macro, and nano. It's probably the only trickiest part about calculations is just getting that right. So it might be useful to memorize that, practice just prescribing between different units, especially if you see it on the ward on placement. Just think about, okay, if that was in grams, what would it be in milligrams or nanograms or something like that. Some other basic calculation things that come up is percentage volumes at the top in the green box. So it's important to remember that 1% comes in, it means 1 gram in 100 ml. And so, for example, at an infusion that was 20% would mean 20 grams in 100 ml. Similarly, things like adrenaline come in descriptions like 1 in 1,000, 1 in 10,000. So 1 in 1,000 means 1 gram in 1 ml, and 1 in 10,000 would mean 1 milligram in 10 mils. And that's especially important because you might get, I know that it's different, the doses of adrenaline are different for different indications, so it would be good to get that right. Yes. And so we're just going to move on to questions. I think I maybe ran through that really quickly, but it was only because to get through to the questions. Was that an okay pace for everyone? Thank you, Anna, for putting that in the comments. Is that okay? Are we happy to move on to the questions? If there's any questions, please say now. Or if you want to go back to any of the slides and screenshot them, we can go and do that now as well. I'll just double check the chat. Cool. Thank you, Lizzie. So I think the timings for these questions, we'll try to do 3. I think realistically we would suggest maybe 5 to 6 minutes for the actual prescribing questions and about 1.5 minutes for the calculation questions. So we can do that for some of the calculation questions, but I think for the prescribing, in order to get through everything that we want to get through, we might just do a little bit quicker and do 3 minutes for each prescribing question. Obviously, if you don't have enough time or you run out of time, don't worry. This is just to run through everything, and we can talk. We'll talk through the answers in more detail. So, if everyone's happy, we can proceed. So, this is the first calculation question. I'll start the timer if everyone wants to get their pen and paper and calculator ready, and then we can start. So I'll start the timer now. Okay, so we'll move on to question 2. And time for question 3. Okay, so the next few questions will be prescribing questions, which will allocate you all 3 minutes for. So I'll start the timer now. And get your BNF up if you haven't already, or medicines complete, whatever you want to choose, and you can use that. So I'll start the timer for 3 minutes from now, if everyone is ready. On to the next question now. On to the next question. On to the next question. To question 8. Can we move? Yeah. On to the next question, please. And on to the last question. Ooh, technical error. Okay. Okay, great. Questions all done.
Okay, brilliant. So everyone just wants to take a breather. If you've got something written down, great. Don't worry though, we're going to go through them now. So what we'll do is we'll do it like last week. So before we click on the slide, Vicky, I'm going to get people to put their answers in the chat, and then we'll go and see what answers I've put. So for question 1, which was a calculation question about a patient with pyelonephritis getting gentamicin, what volume in milliliters did people get? If they can put that in the chat. So what volume for the first dose did people get? If anyone got an answer. Someone suggested 59.5 mil. We've got 2 people saying that. Any other suggestions, or is everyone happy with 59.5? Someone said 60. Okay, probably thinking about like the practicalities of giving it. 59.5. Yep, okay. So if we go to the next slide, Vicky. So yeah, I got 59.5 mil here, and to be honest, I don't know what the nurses would actually give. I know obviously a syringe, you can give half a mil. So I think that would be very possible here, and I would probably write in the PSA, I would probably write 0.5 mil here rather than rounding. Just in terms of my workings, I've put them there for everyone in case anyone got different answers. So you take the dose you want, you times it by the weight, that gives you the overall dose you want. So 7 milligrams times the 85 kilograms the patient weighs. Then you've got your strength, and basically the way I convert is I say what have I got and what do I want and how am I going to get there. So I know that 20 milligrams is 2 mils. So then you take the 2 mil, I divide that by 20 to get how many mils gives me 1 milligram, and then I times by the milligrams I want, so 595, and that gives me the mils I want. That's how I do them, and I always write those steps out on a bit of paper just to make sure I'm following the logic. Okay, has anyone got any questions about that before we move on? Okay. Someone said, oh, let me share the feedback link. Thank you for asking for that. Okay, so I'm sending the feedback form for anyone that needs to leave early. Anyone got any questions about the question 1? Don't think so. Okay, so before we go to the next slide, has anyone got any suggested answers for question 2? So this was the question about a patient being discharged home with PRN oromorph, and about how many bottles we would send them home with. I was once doing a prescription on the computer and it came up with 100 bottles. So definitely wrong. I'm going to put that out there. I did notice, don't worry. But it happens when you're on the computer and things are automatically clicked. Okay, so we've got people suggesting 3 bottles. 3 bottles, 3 bottles. It's making me question my maths, but if we go to the next slide, I got 2 bottles. So I've worked out how many milligrams maximum they could have. So I took, if they take the 10 milligrams every time rather than the 5, and then taking it literally every 6 hours, and then every single day, hopefully their pain's getting better. But if they took the absolute maximum we've prescribed, I calculated that as 280 milligrams that they could maximally take. And then if you look at the strength in the bottle, it's 10 milligrams per 5 mil. So you can either do it the sort of, again, how I did it before, so divide by 10 and then times by 280, or you can just look at that and say, okay, 10 milligram, 5 mil, I'm just going to divide by 2. So I got 140 mils is the volume we need. And if they are 100 ml bottles, I calculated that I needed 2 bottles there. The people saying 3, do you now agree with my 2 bottles? Oh, the question said every 4 hours. Okay, I changed it, but I obviously didn't change both slides, so I apologise, and absolutely it would have been 3 bottles, and I sincerely apologise. I thought I'd changed it. Okay, as long as we're all on the same board, like how we're working it out, I apologise. Perfect. Okay, and then the last calculation question was asking how long an infusion would take given the sort of volume and rate that I'd given you, and that was for IV ciprofloxacin. What timings did everyone get for that one? Yes, Ria, absolutely. If it's 4 hourly, it comes to 2.1 bottles, so you'd probably have to give them 3, which is why I changed it to 6 hourly so that it wouldn't be potentially overdosing the patient by giving them loads. Okay, so for question 3, everyone's suggesting 60 minutes, apologies. So if we go to the next slide, Vicky, that is absolutely what I got. Basically, this is quite a simple question. So you divide the mils by the mils per minute and get the 60. If your question's asking the opposite, so you've got the minutes and the volume and you need to find the rate, it will often come out with something with lots of decimals. And that doesn't mean you're wrong, like Julie said earlier. Just read the question, think, do they want you to give sort of full amounts? Do they want you to give something with decimals potentially? And sometimes they may state to 2 decimal places or to 1 decimal place. So be sure you give an answer with the right number of decimal places if they state it. Okay. You don't always have to have a nice round number to be right. And just another thing on calculation questions, I would strongly recommend going on the Geeky Medics website. They have a page on calculation questions, different examples, different types, with worked sort of explanations that I found really helpful when I was revising. So we've only done a couple here. I would strongly recommend Geeky Medics page. Someone's put up a question. So the question, does the infusion only include 1 dose? Yeah, so we're giving them 400 milligrams 3 times a day, and the bottle has 400 milligrams, so you need a separate bottle for each dose essentially, and the rate that it's put up at is going to be calculated individually each time you put it up because it's 8 hours in between. Okay, does that make sense? If it doesn't, message, but for now we'll move on. So the next question was the one about prescribing HRT. Now with prescribing, there's often, okay, we've shown you the answer that I've put. There's often more than one correct answer, and they take this into account in the PSA. Okay. I think we've shown the answer, but does anyone want to suggest what answers they popped up? What answers did people get? Okay, we'll go on to the next slide because we've shown it anyway. Okay, so I went for a Lest Duet, which is an oral combined HRT thing, and you take a tablet every day. Now, if you look on the BNF, it talks about like the different colours the tablets come in. The PSA doesn't really like allow for that, so I wrote it out how I imagine. They often, if it's like a brand dependent thing, like a, you know, inhalers, often you need to write the brand, or things like this, it will have the full name written out and the brand name to choose from, so be very careful with your drop down options. I've highlighted things in this question that are super important to your choice of HRT. So her last period was 6 months ago. We call that perimenopausal. So if you've had a period any time in the last 12 months, you're perimenopausal. If you've had no periods for 12 months, then you're postmenopausal. If you're looking in her past medical history, there's no sort of talking about hysterectomy or any removal of the womb. which is really important. We'll mention that on the next slide where that's important. And in her current prescription, she's not on any other sex hormones. Okay, she's got no, I hope, no contraindications or interactions. I didn't write any intentionally. And in the question, it very specifically says she'd prefer something oral. That's really important. They'll often say, the patient would prefer a patch or oral or then nil by mouth. So you need to prescribe something that the patient is going to be happy with. Okay. I'll talk a little bit in a second about why I chose this Alest duet. But it contains estrogen and progesterone, and that comes in 2 different strengths of tablets, the 2 different colours, to mimic the natural hormone cycle. Okay. So if we go on to the next slide, I can see there's a couple of comments in the chat. The question stated that she wanted a patch. Guys, I'm very sorry. So the person who put Everil Sequi, that is the patch equivalent, absolutely, because it's sort of sequential, okay, and that's got both estrogen and progesterone, so that would be the equivalent to Alest duet. I'm sorry, we obviously things did get changed in the slides and then didn't get changed back. In terms of where in the BNF you find the formulations, so this is an example of where you don't, and you have to learn it, which is why I've done a slide on it. I couldn't find, you can't find sort of what you give to whom. So it's important to learn some examples. In answer to your question, Christine, it's not that you shouldn't prescribe the brand name, it's that on the PSA, usually you have to type in the actual generic name and then it might come up with the generic name and different brands, and then you need to be very careful about what you're choosing to make sure it's the one you want. Okay. So in terms of how you choose what you want, you need to ask, do they have a room? Do they not? And are they receiving progesterone from something like an intrauterine device? If they have had a hysterectomy or they have a Mirena coil, you can give them estrogen only. Otherwise, everyone needs progesterone with it. Okay. And then whether they're perimenopausal or postmenopausal determines whether they can have the sequential, like cyclical HRT that we've done in this case. So that would be Alest duet, or for the people that correctly did the patch, I apologise, was Everil Sequi. Okay, but if they are postmenopausal, you can do continuous HRT. That's the same dose throughout. And there are some examples on the screen, but there are more. Okay. Okay. I apologise for the patch oral thing. Okay. Has anyone got any other questions about this? So like I say, a table like this, I got this off sort of GP notebook. It's not on the BNF, unfortunately, unlike some of the other really helpful treatment summaries. So why can't you put Everil Conti? So that is because she has had a period about 6 months ago. So she's considered perimenopausal rather than postmenopausal at this point. So we'd want to give something sequential, not continuous. Okay. Okay, brilliant. So, what did people put for the insulin question? How do you choose the strength? Is that for the HRT, I'm assuming. So I believe you would start with sort of the lowest strengths and move up depending on symptom control, because obviously hormones, they do have considerable side effects. So you're going to want to sort of give the minimum that's controlling their symptoms. Okay. No idea what dose to give for insulin, couldn't find anywhere. Lizzie, you are describing how I felt in the actual PSA exam when it asked me to do insulin, which is why we've done this question. Could not find the dose. Yes, so the BNF, really helpfully, says something like, according to requirements. Yeah. Someone suggested insulin glargine 1 unit nightly. Someone said they chose insulin detamir. Yeah, so if in the PSA, I mean, if it lets you do according to requirements, that's great, but that's usually for your sort of meal doses. Usually their long-acting insulin is a fixed dose. So if we go on to the next slide, we can start going through how I got to my answer. And like I say, there are lots of different answers, and you might have different guidance at your hospitals. So very much in real life, you'll be guided by your local guidelines and your diabetic team. But this is a good sort of general principles to follow. So the BNF, all the information I could really find on there is that the first line long-acting basal insulin is twice daily insulin detamir. Okay. So that's why I chose that here. There is a type 1 diabetes summary, which is where I found this recommended insulin regimen. Okay. And crucially, I chose the Flex Pen pre-filled pens. You don't want your patients at home drawing up their own sort of random amounts of insulin. You want it to have pre-filled so that they can safely inject without making any mistakes. Okay. How did I get here? So I based it on the weight. So if everyone just remembers, the weight was 40 kilograms. Okay, we'll go to the next slide, and which will hopefully show how I work it out. If we go to the next slide, Vicky. Amazing. Okay, so when you start insulin for the first time, more so in type 1 diabetics, you work out their total daily dose that they are going to need by dividing their kilogram weight by 2. Okay, so for a really nice simple example, someone that weighs 60 kilograms needs 30 units in total a day. And for a type 1 diabetic, 50% of that is going to be long acting and 50% is going to be rapid acting. Okay, so the maths worked out well here for me. In my trust, we do Lantus rather than Levemir. So we did, and that's once a day. So 15 units, because it's half of the total daily dose, which we said was 30. So they get their 15 units at night, and then they get rapid acting, the other 15 divided by 3, because you have 3 meals a day. Okay, and you normally go for Nova Rapid to have with your meals. Now, obviously, BNF has said Levemir is first line, so our trust is obviously doing what it wants. So for our patient, I then divided I think I got, was it 10 for our patient? And I divided that by 2, so 5 units BD, because this was a child that was just weighing 40 kilograms. Okay. What are the questions before I carry on? Is this the same for children and adults? And is Levemir the same as Detamir? So Levemir, I'm pretty sure, is the brand name. I apologise. So insulin Detamir is Levemir. Okay. In the question, no, it didn't say it was a type 1 diabetic, but it was a 13-year-old. And she only weighed 40 kilograms. So, and there was also a history of autoimmune sort of hypothyroidism in the family. So that's what I was trying to get at. It wasn't a sort of older, more overweight lifestyle kind of thing. And there was no family history of diabetes, which is more common with type 2 diabetes. Is it the same for children and adults? I'm going to be honest, I don't know. If you want to message our Instagram page, we can, or maybe we can put an update in our email. But I would assume sort of, yeah, children are more likely to be type 1 diabetics for the sakes of these questions. Equally, I think it's more likely that you'll get sort of diabetic emergencies, so be confident about your prescribing for DKA or like hypoglycemia, which we will go through a bit later. But if you're asked to start the dose, think about like this, and then your rapid acting is basically a third times 3. Okay. For type 2 diabetes, your long-acting is only 20% of your total daily dose. And they might not then have anything with meals, okay? Not for prescribing, but for prescribing management questions, you would often be asked, do you need to change the dose if they're having high or low blood sugars? Okay, and it's really important for these planning management questions, whether they have low or high glucose, problematic glucose in the morning or the evening, you change the dose that's the other time of the day. So for example, if they're having really low or high BMs in the morning, you would change the evening dose, because that's what's going to have the effect on the next morning. You don't sort of reactively change the morning dose, because that's when the problem's happening. You change the long-acting dose in the evening, and vice versa. Okay, and when you are changing doses, don't just suddenly, halve it or double it. Make changes 20% at a time. So if they're taking 15 units a day, you could increase or decrease by 3 units. Okay, and you would never just stop long-acting insulin, even if they're not eating and drinking, but you can stop a short-acting if they've missed a meal. Okay. Equally, if they're having surgery the day before and the day of surgery, you'd reduce any long-acting insulin by 20% just that day. Okay. So someone said, how did I choose which Levemir pen? There's a few different ones, all with the same strength. Yes, absolutely. So here is where it's really important to see what the difference is. I chose the pre-filled pen. That was the difference. The other ones they were like cartridges or something for drawing it up yourself. You want the pre-filled pens. Is the safest device. Okay. This is why we give like Nova Rapid usually as our sort of shorter acting one, rather than things like Act Rapid, because that one requires drawing up into a syringe. Okay. Yes, the session is being recorded. Someone's asked, can you not give 10 units once a day? So yes, if you were giving something like Lantus, you would give 10 units a day, but because I was going off what the BNF says, and it says first line is BD Detamir, that's why I gave 5 units twice a day instead. Okay. Perfect. Any other questions on the insulin before we go on to opioids? I had a patient today tell me they'd had a lot of cocodamol and then just like giggle about it. I still don't know how much they've taken, but I'll never know. Okie dokie, I don't see any more questions about insulin unless I've missed any. So what did people put for the opioid question 6? I was asking for breakthrough pain relief for someone that was on a buprenorphine patch. Where did I find the information originally? Is this about insulin? Okay, so in answer to Lizzie's question about the insulin, so again, the topics we've chosen today are things that aren't sort of on the VNF, unfortunately. So they're things that we thought it's important for us to sort of go through and explain and for you guys to learn, because the questions that are just sort of like, what would you give, how much aspirin would you give for ACS management, that kind of stuff is very clear and easy to find, so you just need to practice finding those things, whereas for these ones we thought we'd go into the slightly more complicated ones to help you guys. Okay, so Sophie said she couldn't figure out the strength of the patch. Absolutely, that's something we can go through. Anyone have any suggestions for the breakthrough pain relief for question 6? I made this question like specifically mean, so don't worry if you weren't sure. Someone suggested 20 milligrams morphine. Someone suggested 21. Beautiful. Okay, perfect. Let's go to the next slide. I've got quite a couple of slides now on opioids, so we'll go through them in turn. So this is just a reminder of the question. So it's the 52.5 patch. Okay, we'll come back to that, what that means in a moment. In fact, no, we won't. We'll do that at the bottom of the slide. So the patches, no, sorry, go back one, Vicky, for me. Patches, but these numbers that come with them. Can we go back one, please?
Sorry, it's just taking a while to load.
Oh, no, that's fine. I wasn't sure if it would crashed or not. Okay, so with fentanyl and buprenorphine patches, they're written with like a number in little commas, okay? That means micrograms per hour, okay? So these patches, you slap them on, takes a few hours for the levels to build up in the blood and take effect, but they are releasing that many micrograms per hour, okay? And they come in, patches that last for 3 days, 7 days. I'm not sure if there are other sort of lengths of days, but the number tells you what they're releasing in micrograms an hour, okay? And we'll look at the BNF in a second, but basically the BNF tells you what that is equivalent to in morphine if taken orally, okay? So if we go to the next slide. So at the very top in the right hand side, I've just taken a little screenshot of there's a big table there's a buprenorphine table and a fentanyl table, and this basically says the very top, in fact, it's covered it up. Oh, have we not got my animations? Okay, no worries, guys. So underneath this, if you look on the BNF under pain relief, there should be a table for buprenorphine and a table for fentanyl, and it says what each patch is equivalent to in oral morphine. I'm afraid we can't see it because it's not animated itself, okay? And it will tell you, when you look at it, that 52.5 micrograms an hour is equivalent to having 126 milligrams of oral morphine a day, okay? So now we have our total dose of equivalent morphine that we're having in the day. We can work out our breakthrough doses that we want to give. So we want to give between a tenth to a sixth of the overall 24-hour dose, which is any modified release and immediate release opioids they're taking. And we want to give that every 2 to 4 hours, okay, which you can see here in the bit that I've highlighted where I've screenshotted from the BNF, okay. Now, usually you would use an immediate release version of the same slow release background drug. So, for example, immediate release morphine and slow release morphine, slow release oxycodone and immediate release oxycodone. However, fentanyl we don't give as an oral equivalent. So you have to use either morphine, or if they're renally impaired, use oxycodone. Okay, that's how you that's the drug you use, and that's how we're going to figure it out. So if you go to the following slide, I've worked out the maths, the question answer, so to speak. And I also got 21 as the highest dose we're giving them. In reality, you'd write a range, and I've suggested 10 to 20 is a sensible range, because you've got to think about what the tablet strengths are as well. I think if you put 12.6 to 21, a nurse would come and not be very impressed. But they will have a range of answers they allow, as long as it's within a safe range. Okay. Let me just check in on the questions now. Okay, so could you give sublingual buprenorphine for breakthrough pain? I believe that is not the sort of standard guidance. I'm not sure how fast how long that would last in the body, because it's quite a strong opioid. So I think that's why especially with like fentanyl, that would last a few seconds, and so it would be sort of pointless. So Maisie has asked a question that Lizzie has very helpfully answered. So it's prescribing in palliative care. Any question with opioids or like pain relief, please go to prescribing in palliative care and click on the management of pain. Okay, it has all these beautiful tables in it and also little paragraphs explaining things like the calculation for breakthrough pain. Okay, it is definitely my favorite one on the BNF. Would you prescribe as morphine or Oromorph? So you should prescribe as morphine sulfate. Okay, and ideally you'd write like immediate release next to it, but I don't think the PSA exam lets you do that. Yeah, that's my answer to that. You then write that it's oral, etc. Omar, what do you mean by is there an option for PRN? So this is PRN. This is for breakthrough pain. Rather than saying 2 to 4 hourly. Oh, I see. So I can't. You need to try out the PSA sort of. What am I trying to say? The PSA online version. It would usually be in a PRN drug chart, so it would be explained that it's PRN for pain or as required for pain. But it's really important when you're prescribing PRN drugs that you sort of say a frequency and a maximum either number of doses or total dose. So for opioids, I tend to write 6 doses a day, but for something like paracetamol, I'd write 4 grams in 24 hours. Or if it's a little old lady that doesn't weigh much, I'd write 2 grams in 24 hours. So is your question in the PSA, is there a drop-down option for as required? Possibly. So you'll have to try that out. Your uni will probably have past papers that you could sort of do to see how that works. Okay, and then if we go to the next slide, which is a bit more about opioids, it's just some safety things. Always check for renal impairment, and if their EGFR is sort of trending down or it's below 30 or even below 45, you might want to consider oxycodone. Below sort of 10 is where you would consider alfentanil, but that would be a palliative sort of care team discussion. I wouldn't just do that on your own as an F1. The most common side effects are the sort of constipation and nausea. It's really important to prescribe a regular laxative. And in any of your like prescription review questions, just remember constipation is a big one. When you want to increase the dose, because they're having sort of several breakthrough pain doses a day, you need to not increase it by more than a third to a half of what they were having before in 24 hours, okay? And for all these calculations, the recommendation is that you convert them using the table that's in the prescribing and palliative care summary and convert them all to their oral morphine equivalent. So if someone was taking say 100 milligrams of codeine, you would say, right, so the equivalent is they are taking 10 milligrams of oral morphine a day, for example. So you'd add up any doses they're taking and then dose increase by a third to a half, okay? But all the answers are in the BNF for the opioid questions, which is beautiful. Obviously, it's the palliative care section, so there is other things in palliative care other than pain management. If you keep scrolling down beyond pain, it tells you what to prescribe for many different other symptoms, things like nausea and cough, I think, and etc. So it's worth familiarising yourself with those things as well. Okay, let me just see what questions people have got. Yeah, so use the practice papers on the official prescribing safety assessment to understand the format. It's very important. So how do we know the max dose, i.e. 6 a day? So often if there is a maximum dose for anything, the BNF suggests it. So cyclazine, 150 milligrams, ideally max a day, paracetamol 4 grams a day. Generally for your opioids, your PRN opioids and your JIC medications, so your just in case medications when someone is dying, we say maximum 6 doses a day. And in real life that is also helpful because it can help. It means the nurses flag to us if the patient's needing more so that we can go and reassess their symptoms. Okay. Someone's Evelyn lost connection. Yes, that would, if you're increasing the dose, you would include breakthrough pain if they are genuinely having it and have been needing it regularly. Just be very sort of cautious not to overdose a patient. Okay. If we go on to the next slide, I promise we're nearly done with opioids. They're just a very important topic and quite high yield for the PSA. This is just another thing about sort of changing opioids, whether it's between different opioids or different routes. You always convert to oral morphine in between to make sure that you don't make any mistakes. So you'd never be like, I'm going to divide my codeine dose by 20 to get my oxycodone dose. We literally have charts in our hospital that say, right, convert to codeine, to morphine, right, and then what do I want? How do I convert that to the oxycodone or the tramadol or whatever? Okay, so write your sort of answers out in calculation questions and be very careful. If you are changing between routes, that's chill. If you're changing to a different opioid, for example, oxycodone because they've got reduced renal function or because they are not really tolerating the morphine, you should consider reducing the dose you give by about 25 to 50% to avoid a sort of overdose during the switch period. This is because the different opioids, especially when you think about the tramadol and stuff, they actually attach to different receptors and different people have different numbers of receptors in the body and you don't know how they're going to react. So if it's safe to do so and the patient isn't in sort of severe pain, reduce the dose as much as you can. If they're in lots of pain, you might only reduce it by like 15%. But it's very important that once you've done your calculations and you've worked out what you want to give, just reduce it a little bit. Okay. Yeah, I've put an example in my notes, but unless anyone wants me to go through that, I think it's pretty clear from the BNF how you do all the conversions. If we go to the next slide, this is the last one on opioids. Oh, I've put the example here. Perfect. Okay, so say you've got a patient having oral codeine. They're taking 30 milligrams 4 times a day, so 120 total. I convert that to oral morphine, so 12 milligrams. Reduce the dose. Here I've gone for reducing it by a third, so because that made my maths easier. So I've gone to 8 milligrams oral morphine equivalent per day. And then I've just converted that to subcut oxycodone. So overall, I know I want to give 4 milligrams. It's quite a low dose. I was just doing the example for the maths. Is that clear to anyone? Has anyone got any questions about opioids before we move on? It's an important one not to harm patients. Okay, if everyone's happy, then I'm going to hand over to Julie and she's going to do her lovely fluid questions.
Hello everyone, thanks for sticking with us. So we'll go on to question 7. So if everyone can just write down in the comments what fluid they prescribed for this patient who is nil by mouth following a stroke. a very real scenario during my weekend of on-calls. Anyone got any answers down for this question? Someone said 1 litre saline plus 0.3% case potassium chloride, 8 to 12 hourly. Anyone else think anything different? Sodium, 1.5 litres over 16 hours. I've got to add potassium, that's okay. And yeah, everyone kind of saying the same thing. And if we go on to the next slide, we'll see the answer, which most all of you are correct. So the answer would be sodium chloride 0.9% plus potassium. You'd want the 0.3% strength, and you'd give about 100 mils IV infusion. And then the other thing that the question will ask you is about the frequency that you can give it over. So you can give that over 8 to 12 hours, and I just chose just 12 hours. But if you put anything between 8 to 12, that would also be completely correct. So if we move on to the next slide, I have a little slide on maintenance fluid. So this is what the question was asking. This is a patient who's had a stroke and he's made nil by mouth. So he's not necessarily, these aren't resuscitation fluids. These aren't necessarily replacement fluids either. They are just maintenance to keep him nutritionally and electrolytally replete whilst he's nil by mouth until he has his NG tube in. So the important thing with maintenance fluids, and the thing that you'll probably really need to revise / memorize when you're revising for the PSA, is the table on the right hand side, and that is your daily requirements. But I'll just quickly run through the kind of fluids that you need to know for your fluids. So the first kind of type of fluid I'd remember is your sodium chloride 0.9%. And this is your most kind of just generic fluid. So in about 1,000 mils of sodium chloride, you'll get 150 millimoles of sodium and 150 millimoles of chloride. And then in your sodium chloride plus potassium, and your potassium comes in two strengths, so you can get 0.3% or 15%. So that will contain the same amount of sodium chloride as I said above, but your 0.3% potassium will contain 40 millimoles of potassium, and your 0.15 potassium will contain 20 mils of potassium. There is also a what was I going to say? I can't remember what I was going to say with that. But then the other third type of fluid that you could give is glucose. So you'd give a 0.5% strength glucose for maintenance, and that in 1,000 mils of that you'll get about 50 grams of glucose. And then you can give, there's also a 20% strength that comes in a smaller volume, and that will give you 20 grams. And that is for when you have any hypoglycemic situations that might occur. I can see there's a lot of comments. I'll just quickly see if there is anything. So not sure if Hannah said, I thought we were doing a whole day, so I did this. Not sure if I hit the electrolytes correctly. 5% glucose with 0.3% KCl, 1 litre over 2 hours, times 2 each 8 hours, and then 0.9% over. Okay, so you've done 3 bags over 8 hours. I'll run through the kind of maintenance requirements. So the table that I've put here on the side. So just for water, each person needs roughly 25 to 30 mils per kilogram per 24 hours. Sodium and potassium, and also chloride, which I haven't put on the table, you need 1 millimole per kilogram per 24 hours. And for glucose, you need roughly 50 to 100 grams every 24 hours. So that gives you the daily requirements in that last column. And I think, Hannah, that would also, what you've put would also apply. So 5% glucose would give you about 50 grams. Yeah, so I think what you've prescribed there does meet the requirements, but realistically, for the nursing team as well, it would probably be easier to prescribe 2 bags over a longer period of time than it would be to prescribe 3 bags over 8 hours each time. So as a general rule, what you can give is 1 bag of salty, which is sodium chloride plus your 0.3% potassium over 8 to 12 hours, and then a second bag, which is another litre, of sugary, which is your glucose plus potassium over the 8 to 12 hours. Does anyone have any questions about that? Isn't giving... Oh no, someone deleted that question. I thought elderly people should get less water though. So that is a very good point, and that is more relevant when you're thinking about perhaps resuscitation fluids, when you're giving someone a lot of water, a lot of fluid very quickly. And we'll run through that in the next few slides when I talk about resuscitation fluids. You're absolutely right. But when you're thinking about maintenance fluids, you also you definitely think about fluid overload and whether they have a history of heart failure. But generally with maintenance fluids, because you're giving it over such a long period of time, 8 to 12 hours, that risk of fluid overload is much less than with resuscitation fluids when you're giving it to them when you're giving them almost half a litre or a quarter of a litre in 15 to 30 minutes. I think actually RE daily requirement, there is a suggestion of 20 to 25 mils per kilogram per day. Out of fluids. So Hannah, yeah, I think you might be right. I'm not familiar with that guideline, but in general, in practice, we don't necessarily prescribe different maintenance fluids for different ages, or at least I don't know if Tess does. We usually prescribe the same level of fluids, and then the most important thing that the PSA probably won't obviously ask you to do is the importance of carrying out fluid balance assessments before and after your bags of IV fluid. So you need to assess your patient after each bag of fluid and see if they're showing any signs of fluid overload or any signs of fluid depletion. So some classic signs of fluid overload are pitting edema, crepitations when you listen to their lungs, and some signs of fluid depletion are reduced skin turgor, dry mucous membrane, so taking a look inside their mouth, their lips and their tongue. Fine. Okay, so I'll move on to the next question. And this was a question about a crash call. So does anyone have any ideas what they would prescribe for this question? So Davina, you've put with 0.18 sodium chloride work as well. I don't see why it wouldn't if you gave it over the correct volume over through the correct time, but it really is just, I think if you prescribe 0.18 saline, the nurses would probably come back to you and say prescribe 0.9 because that is just the standard. Thanks. So would we use 2 of the 0.3% saline? Yeah, you would, because you want to give them 40 millimoles of potassium. Not sorry, 40, 80. Fine. Does anyone have any answers for this question? So someone's put iron glucagon 1 milligram once daily. Lizzie's put buccal 1.5 tubes glucose gel. Omar and Laura have put IV glucose. And a range of answers there. Any more? Fine, so we'll move on to the next question. So I put glucose 20%, 100 mils, IV over 20 minutes. So in a hypoglycemic patient, a patient should be receiving about 15 to 20 grams of glucose. So if we go back to what we spoke about in the calculation section, 1% an infusion volume of 1% means 1 gram in 100 mils. So a 20% bag of glucose gives you 20 grams of glucose in 100 mils. So that infusion volume instantly hits that target of 15 to 20 grams of glucose in an episode of hypoglycemia. If you were to give a 10% bag of glucose, the patient would receive 10 grams in 100 mils. So you'd need to give about 150 to 200 mils of 10% glucose to give the whole dose of glucose that you want to give. Either answer is correct. I just chose 20% because that is, I think, what more people tend to give. But in the PSA, either question would be correct as long as you make sure you give them that full dose of give them at least 15 to 20 grams of glucose in that bag. And I chose to give them IV glucose because in the vignette they have collapsed, so I'm assuming that they are not awake enough to be able to give them a glass of orange juice or something like that, or to give them glucogel like some of you suggested. And if we go on to the next slide, Vicky, I'll just run through the hypoglycemia guidelines. So there is a treatment summary on the BNF very helpfully for hypoglycemia, and unlike some of the things that we've spoken about previously in the presentation, this is actually quite clear. So the guidance is, if the patient is conscious and able to eat, give them a sugar-rich snack. So that's something like orange juice, biscuits, anything that will give them about 10 to 20 grams of glucose, or you can give them some glucogel with the same kind of volume. If they're not unconscious, so if they've collapsed or you feel like they're unable to eat, so that includes if they're drowsy or vomiting, you need to give them something that is not oral. So if they've not got IV access, you want to give them IM glucagon. And in most hospital settings, it's very unlikely that they won't have IV access already, or that it won't be easy to insert IV access. The most ideal option if they're unconscious and hypoglycemic is IV, because then that's just straight in the vein, you know you've given it to them. So if in the vignette it says that they have IV access, I would always prescribe it as the IV glucose rather than glucagon first. So in this case, like I mentioned before, you can either give them 10% or 20% glucose. With 20%, you can give them just 100 mils of it. With 10% glucose, you need to give about 150 to 200 mils for them to reach their full, give them the full amount of glucose that they need to wake them back up. Remember to not ever prescribe, well, at least not for the PSA, at least 50% glucose. It's basically like injecting treacle into their veins, and it's a very high risk of extravasation. So definitely don't do that. And helpful tip for real life rather than the PSA is that after you've given someone hypoglycemic treatment after an episode, there might be some rebound high glucose readings, but you don't necessarily need to treat that, as they'll probably naturally their blood sugars will naturally start to settle. Obviously, unless that's a DKA, then you need to be managing that. But this is just for a normal hypoglycemia. See some questions. So Ria said, due to the decreased consciousness, I think it said they respond to voice instead of being alert. I chose the IM glucagon. Would this get less marks than the fluid option in this context? I completely understand your reasoning there, definitely. So decreased consciousness, so you didn't choose the oral, you went for the IM glucagon. I think it would be more appropriate to give them the IV. Like I said, IV access is the most ideal, and I think IM glucagon is more appropriate for a community setting, or if there really is no IV access or no possibility to get IV access. So I think in a first line, decreased consciousness, give them IV glucose. And any other questions? Oh, no worries. Okay, brilliant. So if we're all happy with the hypoglycemia question, we can move on to question 9. And this was about a lady that you're asked to see because she was responsive but drowsy and felt lightheaded. Anyone put anything down? Ooh. 250 ml saline over 10 minutes. Lovely. Anyone got anything different? 250. Someone said stat. Someone said over 15 minutes. A nice range of answers. So we'll move on to the next slide if that's okay, Vicky. So here everyone got the type of fluid right, and so it's saline 0.9%, which is the classic, the standard type of fluid you give for resuscitation. And I've chosen a volume of 250 mils, and that's because I have put that this lady is 85 years old, which I haven't included a past medical history of heart failure or anything like that. That would be a contraindication, but just purely going off of her age, 250 mils would be more appropriate, as she is vulnerable to be fluid overloaded if you give 500 mils. And it can be given over a volume of stat to a range of 30 minutes. I've just chosen 30 minutes. I think in the vignette itself, it doesn't sound so urgent as to need a stat, but that's just a kind of clinical reasoning kind of thing. I don't think you'd be marked down for giving stat, but anything between 10 to 30 minutes sounds appropriate. It doesn't sound like an emergency crash situation where you'd need to be squeezing the bag into her. She's just the little old lady with an infection, and her blood pressure's just gone down a little bit. So did that question make sense? Oh, and Hannah's put, I don't think PSA accepts stat for fluid duration. So there you go. So maybe you can't give stat, actually. I wasn't aware of that. But anything between 10 to 30 minutes, I would think is absolutely fine to give. And if we move on to the next slide, I've just got a little slide on fluid resuscitation. So fluid resuscitation, I'm sure as many of you know, is just all about reversing the signs of shock. So it would involve doing an urgent assessment, which I will assume that you have done for this question in terms of this vignette. So the signs of shock can be hypertension, so a systolic below 90, someone who's tachycardic, tachypneic, or a capillary refill time more than 2 seconds. So if you get any of those signs in your on examination section in your vignette, then you can assume that they're in some sort of hemodynamic instability. Alongside, if they give you something, a piece of information like they're being treated for an infection, then that's also more likely that they're in some sort of instability as well. And the type of fluid that we give, again, I've gone through, you can give 500 mils of saline or Hartmann's, but I think saline is more standard, over 15 to 30 minutes. And you want to give a smaller volume of 250 mils in patients at risk of fluid overload. So that's if they've got a history of heart failure or renal failure, or if they're particularly elderly. I put my mark of elderly at like 65, which is maybe a bit, I think that's quite dependent. I think frailty has an element to do with it as well. But if you give someone younger than 65, 500 mils, I think it would generally be okay if they don't have a past medical history that would suggest otherwise. And the most important thing, realistically, real life situation about giving boluses is that you want to reassess after each bolus. So you want to see if giving each bolus has affected their blood pressure or that sign or any signs of shock that they were displaying beforehand. If you get to 2 litres of boluses and they're still not responding, that's when you want to call MedReg or speak to someone more senior. Just have a quick look through the chat, see if there's any questions. And Tessa said, I always put 15 minutes. Something like less than 20. Oh, whoops. Sorry. Apologies if that is the guidelines. I've always done it over 15 to 30 minutes, but I would double check that with your guidelines with the BNF, and just see how long over resuscitation guidelines, resuscitation fluids you need to give. Fine. Does anyone have any other questions? Apologies if there's any discrepancies between guidelines. No? Let me move on to the next slide, which is just a quick little Can we move on to the next slide, Vicky?
Sorry, it's just loading.
No, that's okay. Thank you. So this is just an algorithm that NICE has very kindly given us. This is not in the BNF, so do not think that this will be in the BNF. But this is just a kind of something for you to revise and look over, unless it is in the BNF. No, I don't think so. It's just about IV fluid therapy, so it goes through resuscitation and replacement and maintenance, and it's a good little thing to revise and look over, and kind of summarises everything quite nicely. So we'll move on to more IV fluids, because who doesn't love them? I'm just going to quickly go through paediatric IV fluids. So funnily enough, I didn't realise paediatric IV fluids were in the PSA. So when it was my turn to do the PSA, I never ever revised for it. And then when the question actually came up in my PSA, I was really, really confused and quite shocked. So don't be me, and you're not going to be me, because you're going to know that this might come up in the PSA. So pediatric fluids, the PSA will, if it decides to test you on it, will most likely go through a maintenance fluid question or a resuscitation fluid question. Replacement of pediatric fluids is a little bit more complicated, but I cover that in the slides as well. So this slide here, I've gone through fluids for a child that is older than 28 days. This is just for the sake of time, but it's important to know that maintenance requirements for children younger than this would be different. So the normal fluid that you would give for maintenance is sodium chloride 0.9% and glucose 5% for a child, and that is over 8 to 12 hours. And the volume that you give depends on their weight. So for the first 10 kilograms of a child's weight, you calculate the fluid that they need at 100 mils per kilogram per day. For anything between 10 to 20, you give them 50 milliliters per kilogram per day, and if it's over 20, you give them 20 mils per kilogram per day. So by that, if that wasn't explanatory, what that means is for a 15 kilogram child, you calculate their first 10 kilograms at 100 milliliters per kilogram. So that would be 1,000 milliliters. And then for their next 5 kilograms, because they're 15 kilos, you calculate that as 50 mils times 5 per day. So that would give you 250 mils. And then you add those two together. So you add 1,000 mils and 250 mils together, and that gives you a total maintenance fluid for over the whole 24 hours of 1,250 mils over 24 hours. You don't want, depending on their weight, you don't want to give a male child more than 2.5 litres or a female child anything more than 2 litres. And I've just put on the right the guidelines from the Whittington Hospital, which isn't even where I work, but it just had really nice guidelines that I found that I thought were quite clear. Does anyone have any questions about that? Okay, no. And then if you go on to the next slide, I'll quickly go on to resuscitation and replacement. So resuscitation, same as adults, you want to give them, say, sodium chloride 0.9% for a pediatric patient. The volume that you give depends on their weight, once again. So with children, basically everything depends on their weight. And so if you get any kind of question with a pediatric patient, just always, make a note of that weight, because it'll probably be relevant to the question. So you'd calculate the volume that you give by calculating 10 milliliters per kilogram, and you give that over 10 minutes. Replacement, I won't go through in too much detail, but it is on the slide, and I don't really think the PSA will go through it. But replacement fluid is a bit trickier. It does involve a little bit of calculation. The type of fluid that you would give is sodium chloride and glucose 5%. But for replacement, you need to calculate a child's percentage dehydration. And for that, you need to know how their weight when they were well and their current weight. And then you calculate the percentage of that. And then using that, you calculate their fluid deficit, and which is all on the screen for you. And then you calculate their total fluid replacement by removing their by adding their fluid deficit and their maintenance fluid volume. I've put a worked example on the right hand side for you to look at in your own time when you get the slides. I appreciate that we're 45 minutes over the time, so I won't go through it at this moment, and we'll go on to the Next question, which is the last question. So this was a question about asthma. If anyone has any questions about fluids, please feel free to put them on the chat. Apologies if it feels like I'm rushing through this. So any questions for the 25-year-old university student complaining of shortness of breath? So Omar's put beclometasone 400 micrograms twice a day. Anyone else think anything different or agree? No. Okay, we'll move on to the answer slide in that case. So yeah, absolutely right. Beclometasone 400 micrograms BD. And so this is very easily found in the asthma chronic treatment summary. If you find that treatment summary and then Control F, because remember Control F is your best friend, and quickly type in adult, if you really can't be bothered to scroll down, you'll be able to see the BNF summary that kind of explains that very succinctly. And I've just put on the right hand side the what the beclometasone monograph looks like on the BNF, and it suggests prophylaxis of asthma 400 micrograms twice daily. I just went for the upper range, but if you prescribed anything between 200 to 400, it would also still be correct. So if you move on to the next slide, I've got a little summary of adult chronic asthma. So the BNF treatment summary for asthma offers both NICE and BTS guidelines, which can be a bit confusing. I personally think, and it's true that the PSA won't penalise you if you choose to follow either guideline. So if you choose to follow the NICE guidelines or the BTS guidelines, both are on the BNF for you to use and to follow. Whatever you choose, just make sure that for each step you're following the same guidelines. So don't follow NICE step 1 and then BTS step 2. Stick to the same guidelines and practice and revise using one or the other. Don't on the day of the PSA start for some reason reading the BTS guidelines when you were during revision using the NICE guidelines, just for consistency and just to kind of avoid any easy mistakes. And I've just put down, so on this slide I've used NICE guidelines just because that's what's most familiar to me, and so I've just put down a stepwise ladder of chronic asthma. So with this patient in the vignette, he was on Salamol, which is salbutamol aceba, and he was showing signs of nighttime kind of breathlessness and more regular use of his Salamol inhaler. And those would be both indications to start a low dose inhaled corticosteroid. In BTS guidelines also just suggest that if a patient's had an asthma attack in the last 2 years, that would also be an indication to start a steroid if they don't have one already. And on the left-hand side, I've put just some kind of generic and trade names for common asthma drugs. So I put in the vignette Salamol as in his kind of medication history and not salbutamol, and that's because I think sometimes they like to kind of keep you on your toes and give you the trade names. So salbutamol can come in Salamol, Easyhaler, or Ventolin. Beclometasone can be called Clenil or Soprobec, and beclometasone with formoterol can be Foster or Leuferbec. So if you type in, if you don't know what they mean, just type it into BNF. Almost always they will have their trade the trade names associated with the generic names, so you can always type it in. Yes, and just double check. I think this is one of those questions where I personally get a bit confused because I do think that the asthma guidelines are a little bit confusing with what to add when. So definitely get up the treatment summary as soon as you see an asthma question, and then you can just follow the steps as you go. Does anyone have any questions about that? No, lovely. So that is all of the questions and all of the answers done. Thank you everyone for coming. I think we've resent the feedback form for you guys to fill out, and that will mean that you can get slides available to you as well. And remember that this is the second of our 4-part PSA series, so we will be doing another session next Thursday, and that will be on prescription review, and then we'll be doing another session the week after that, and that will be on everything else in the PSA, and we'll be at the same time, same link. And if you move on to our next, skip a few slides, Vicky, yeah, and the one after, yeah. And if you follow us on our social media, you can see all of our events and keep up to date if there's any kind of event changes or anything like that. If you have any questions, please ask us on the chat now, or email us on the email address on the screen, or Facebook us, Instagram us, anything, any form of contact. TikTok us if you want. Don't know how you would do that. But thank you everyone for coming.